All right, welcome guys. Today we're going to be talking about SOAP notes. More importantly, how to write a SOAP note. As therapists, it's so crucial that we write good, concrete, objective notes for many, many reasons. And we're going to kind of cover that today. So hopefully this can kind of guide you. See that SOAP noting is easy, but also essential to be able to practice as a physical therapist. All right, so first, what is a SOAP note, right? You hear that term, you probably a little bit confused. Simply, it's just an acronym: subjective, objective, assessment, and plan. And these are the four parts of a note. Used to, you would see it all in all documentation that way. Now that we're getting more into EMR, it's still there, but it might not be as well defined. But ultimately, this is going to be in every single note that you do, or more importantly, if you cover all of these four areas in your note, it'll be a very credible note. All right, so why though? Why do we care? Right? Why are we going to spend so much time documenting and making sure that we document appropriately? Well, first is we need to justify our services. We need to justify our services to patients, but also to insurance companies. We need to justify our services to, referring providers. It's crucial that we justify the services rendered at the time of the appointment. Also, we need to justify these things for billing. If I am going to claim that I did these things with the patient, or I should continue to treat this patient, I need to justify that. So our documentation goes a lot into billing, and in a sad way, it can determine if patients are able to get more visits or less visits, etc. It's a way to communicate between us and MDs, nurses, between each others, and also to ourselves as well as we continue to see this patient. And then finally, it's a CYOA. We'll keep it PG-13 here, so CYOB. It's the cover of your own butt. Your documentation, your SOAP note, is an illegal document. What's in it is what you're saying you do. You can be held liable. More importantly, what you don't have in that note, they say you did something in the session, but you don't have it in the note, you can't claim it, because that note is your statement, your legal documentation that what you did is within this statement, aka the documentation. So it really is crucial that we document to our fullest to protect ourselves. Again, it is a very small number that this becomes an issue in cases of physical therapy, etc. But in the cases where therapists did go to issues of civil litigation, or they went into issues of actual, criminal law, documentation is often the thing that saves people, or more often hinders them than anything. Okay, so let's talk about subjective, right? What does subjective mean? This is going to be the first part of your note. This is going to be the area that you really want it from the patient perspective. I put on here their words, and that's it. It should be quotations around what they say. They ask them about previous treatments. How are things going in their life, functional, etc. Any changes in medication or medical status. That's a huge thing to cover, because it can greatly affect our treatments with patients. And then finally, something that we often need to be documenting is their HEP. How is it going? This one is great to put in subjective, but two, it keeps us honest, so we can make sure that we're updating it if we need to see fit. Now, subjective is hard to do sometimes because patients can ramble, or patients could be the one-word farmers who say, good. It is hard. So my suggestions are really covered under these four ideas. First, how did you feel after last session? You might have noted down what they did or how they felt, but how did they perceive they felt? How did you feel after your last visit? How did you feel, 24 hours later or into the next day? Those are crucial because between session changes is one of the key indicators that a patient's actually going to get better. Another is, how is your blank? And this is your primary complaint. Fancy terms is subjective asterisk. This is just the thing that is really meaningful to that patient, that you can continually go back to them and ask, how is this? How is this? It's going to allow you to see, is that functional, but more importantly, meaningful thing to that patient changing? Another thing that you can kind of progress with is how are you doing with increase, like some type of objective measurement that you have been doing. Let's take the example of a shoulder, right? I might ask the patient, how have you been sleeping? Because patients in shoulder pain, with sleeping don't mix often. How are you doing sleeping? That might be their primary complaint. Then I could talk about a little bit more objective. Well, how's, getting that arm up and overhead, like for top shelves or reaching the arm behind the back, etc. So, one subjective thing, and then try to tease out an objective thing as well. And then finally, again, covering that HEP. Can you show me your HEP? Every once in a while, just challenging the patient to see if you can cover any holes, but more importantly, update it as needed be. Now, here are some examples of subjective, bad and good. I'm not necessarily going to read these, but the things to keep out is bad is going to be very simplistic. It's going to be very broad in general. It's not going to be catered to that specific patient in front of you. Versus the second one in the good category, it's specific to the patient. And that is the key with subjective. And it's going to keep you honest as well, is what are those things that are meaningful to that patient, and are you asking about those things? And if you're like, well, it doesn't change often for my patients, there you go. That is the thing that you need to be asking, because that's what the patient cares about, and so we can keep up with that via our subjective documentation. All right, objective, right? So objective needs, what is in it? Well, again, we're talking about a daily note here, not necessarily an eval progress note, so it changes depending on which note you're writing. First, it needs everything you did, and also evidence of progressions. Yes, I know that patient for 30 visits has probably done lower trunk rotations, 3 sets of 10, but have you changed it, right? I remember once seeing a patient who had been doing chin tucks 10 for 10 seconds and 2 other exercises, and they're on their 20th visit, and there was 0 progression, right? So our measurements, we need to show progression there, but we also need to show it with our exercises. We need to show activities or neuromuscular EED with our skilled care. It needs to have portions of it that dictate what we're doing for that patient. That's just not a simple exercise. So we need to show skilled care here with those patients. Manual treatment, if it's being performed, you need to dictate it, you need to justify it, and you need to write down kind of a little bit about, description, grades, etc. All right, activities. Everything that's been done needs to have the total minutes if it's a time-based unit, and also the CPT code that is also there. Any modifications you did is crucial, right? So if a patient's doing single limb stance and, they're a couple fingers down, that needs to be done. If they have handheld assist, that needs to be done. All that little nuanced things that we do, it does need to be in our documentation. I'm not saying that every single little thing that patient lifted their right arm off this time versus the left. I'm not saying that, but things that show skilled care and modification are an absolute. Finally, this one is a little hard for some people, but it truly needs to be in your objective session, is there needs to be change at least every 2 weeks. I actually argue that you need to be changing something objectively every other visit, which, tends to be 1 to 2 weeks between, but you absolutely need to be showing that change. And again, it keeps us honest, because if the patient's not getting better, we need to figure something else out. All right, so what are some suggestions? First, absolutely, we need to have portions in our objective that this patient has been screened, and I would argue actually being continually screened. Blood pressure, it could be great once, but if that patient has blood pressure or heart issues, etc., it needs to be done every time. Test, treat, retest, another crucial part of your objective examination. We need to be showing what are we looking at as that primary asterisk signs to help that patient get better. Reasoning. Why did you do what you do, right? Why did you progress the patient to those stairs or to do that exercise? Add in some of that, right? Because that's your clinical reasoning, and you're justifying the high level of care that you're absolutely giving those patients. And then finally, activity. Put in what you did. Make sure you're showing progression of what you did, and then the rationale as well. Now, here are some good and bad examples. Again, I'm not going to read through all of these things. What I want to show is specificity, changes that was made, are all crucial, these things, any assistance that is needed. Also, if you see in the bad, it's just subjective reporting, right? Where a lot of people fail, and what I've seen most clinicians fail when I'm auditing notes, is they add too much subjective in the objective. Objective should be short, clean cut, and making small little changes as you go along. It should not be spending where you're going to write your narrative, paragraphs, etc. Here's another picture of objective examples. I know this might seem a little long and daunting. Keep in mind, patients generally do close to the same exercises every time. They change them sometimes, so if you just type in new ones, or if you have a flow sheet and you're typing in, this is small little changes you're making as you go along. It's very easy to keep up with, but it's very hard to completely change mid plan of care, or it's really hard to change when going from scratch, right? So these are crucial that we started at the very beginning and that we keep up with it. Now, assessment. This is the bread and butter. This is our why. This is the part that truly justifies why we're treating this patient, what we did. The problem with assessment, though, and again, with auditing, this is where I often see people miss the boat. They either feel like they're just talking to a group of physical therapists, or it's, lack of better words, so shallow. It truly is a kiddie pool, if you will, right? So first, let's talk about the assessment. You need evidence of PT intervention, right? If you just listing all the exercises the patient did and that they did well and they continue to progress well, great. Why did they need physical therapy to begin with? What was the point of them coming to you? You're a physical therapist. You just watch them exercise, right? And that's not what we do. And there's nothing wrong with just exercise-based physical therapy. There's everything wrong with not documenting it to the point where you're justifying your care, your services received, right? Second, treatment successes. Treatment successes, but also that matter functionally, right? So if a patient is able to increase balance time, if a patient is able to increase ability with gait abnormalities, those are great. But again, who are our notes for? The doctors or the insurance company, etc. They might not know their exact lingo, so you need to point it to what they don't understand. So if you're able to improve a patient's ability for cone step overs, that is actually enhancing their ability for independence. It's reducing their fall risk, so therefore the patient can be more independent at home or more able to get out into the community, etc. You have to point these things out to be able to show that we are making functional changes for that patient. Finally, barriers. Barriers, we really need to be discussed. It doesn't have to be necessarily on every daily note, but it needs to be in there if we have barriers that are hindering us from these patients getting better. So that way we have basically a little bit of a timeline showing, yes, we're having hindrance based on this, this, and this. So when these daily notes further go into, say, progress notes or reevaluations, we can justify that these barriers have been there and what we've been doing to counteract them as well. So, huge long note. You can pause the video and read with all these things. If you read it, what you're going to notice is, one, it's very vague, very general. You can say about most patients and what we're doing with most patients. And it gets specific that's important to physical therapists, but not necessarily how it's important to the patient. Right? We're not justifying care to that level it's going to change for the patient. So we have to add that function in somewhere. So that's where this assessment example is missing at. It's missing that specificity to the function of the patient and way too mumbo-jumbo junk, to be honest, right? It's just basically our vocabulary thrown in a blender, popped out, add no muscular retraining, and we're good, right? But that's not what we do. We need to be intentional in how we document, just like we are in our treatment. Now, here's another example. This is often what I'll see in daily now, and I understand it. right? The clinic is hard. Getting notes down sometimes can be extremely challenging, but this shows no skilled level of care on this example, right? But oftentimes this is what we're putting. So, with our assessments, again, like I said, I understand the clinic can be hard, but at least, I always had the rule that if I'm seeing a patient twice a week, one of those needed to dive deep into things, and one of those could be stay a little bit into the shallow waters as long as I adequately documented that visit, right? That's not a bad strategy. Find what works for you. But if you're putting this on every patient that walks through the door and you're not, you're only doing some meaningful documentation in the assessment at progress notes and reevals, this is time to really re-examine. Are you seeing too many patients? Are you doing too much? And there's better ways to be efficient with this. A good example, many things to point out is, what are you treating? What did the patient feel? What did it improve? And how did it mean for them, right? Maybe add a little bit of what you're hoping to achieve next visit or progress the next visit. That always can fit in plan, but I'll be honest, some EMRs, the plan's just a checkbox. So I usually try to put what I want to do next visit in my assessment so I can quick read it when the patient shows back up. All right. So let's talk about the plan, right? Again, it simply is the description of the treatment that will change the next visit, right? What are you going to do next? It needs a couple of things. One, you need to set yourself up for success, or even someone that comes behind you. It's so crucial that our patients, or those ideas that we had about our patients, those little things we saw, we need to document that. I've been treating well over 10 years. I can absolutely promise you that fantastic idea you had on that patient that you're like, man, next time we're going to try this, you probably won't remember it. If you've been like me, you've had that great idea about 5 times in a row, and finally the patient's like, oh yeah, you mentioned that last time, and you're just like, whoa. Or you might even have that deer in headlights moment where the patient's like, man, I'm really excited. We're going to try that thing you talked about. And you just stare at them and you're like, I have no clue what you're talking about, right? This can help you with the plan, is putting specific notes in there to help guide you for your next treatment. Also, any modifications of goals, any updates to goals, anything like that can go in there and definitely help you out. So plan examples. Oftentimes we see plans as patient will be progressed as tolerated. Awesome. That is beep, right? That's not good. That's terrible, right? We need to be above that. Again, documentation, I understand, but we need to step to that next level. Spend one more minute adding in that little bit of extra, right? So what are we going to focus on? What's going to be our ideas to do next time? What are some changes that we might need to do for either HEP or for our exercises for those patients? Those are things that we got to hit on. All right, so I'm sorry, that's a lot. I know this isn't the sexiest topic, lack of a better word, but it's a crucial topic, right? It should, I always say there's 3 major things. One, it is legal documentation that is truly there to protect you. 2, it's communication. It's communication to you, doctors, nurses, etc. Really you. I mean, you're the one that's going to be reading most of these, going back and looking at them. Let it enhance your patient care, not hinder it in any way. And then the third one that this really can help out more than anything is to make sure that you are justifying the services you provided for that patient, ultimately insurance companies are looking at your notes and dictating whether they should pay or not. And for a lot of people, if your notes are not that good, that is either going to fall on the clinic or the patient. Oftentimes it falls on the patient. And if you've ever had this, and this is truly a heartbreaking moment, your documentation could be the difference of someone receiving care or not, right? And we don't have to get into the ethics of that by any means, but just think about how terrible you're going to sleep at night if your documentation does not do a good enough job to justify a continuation of care, and that patient that desperately needs it is denied visits. And they can keep coming to you, but they might have to be at 100%, etc. Unfortunately, I have been there, and that has made me greatly question what I put in my notes and spend a lot of time trying to determine what is required and needed and necessary, but at the same time limiting me from the time on the computer where I can spend more with patients. And if you do all what I've kind of talked about today, easy, quick, 3 to 5 minutes, you can knock these things out and progress and kind of document as you go. It can leave you more and more time with your patients. All right, so key features, right? Subjective examination, response, how do they feel, etc. Their words, and functional impairments, talk about them. Objective examination, where's your measurements, where's your activities, making sure that you show skill within that. Assessment, why did you do any of these things that you did in that tracement session? Point back to function. No one cares about what the knee can now do. They care what it means for that inpatient, right? What does it mean for an activity limitation? What does it mean for participation restrictions? Those are what you need to focus on. And then you need to justify the services within that assessment as well. And then finally, plan. Set yourself up for success next time, right? Ideas for next visit, connect to your goals, and progress from there. Ultimately, that is how you fill in a daily note. Again, like I said, it seems like a lot, but ultimately 3 to 5 minutes, especially if you have a good system, you just got to make sure that it covers all the necessary areas that you're supposed to. Guys, thank you so much for watching. Hopefully this clarifies notes a little bit better. If not, please in any way reach out to me, via email, etc., that I can go over and help you guys out. Because most importantly, like I said, notes can be a way for you to thrive in patient care, or it can be a way to truly hinder you with your patient care. Let it be a way for you to be able to truly strive. Thank you so much for watching, and look forward to hearing from you guys.